Okay, let's unpack this. We are diving deep today into a genuinely challenging situation for anyone involved in breeding dogs and cats, uterine inertia.
Hmm.
You've sent us a stack of articles, research papers, and our mission, really, for this deep dive is to cut through the complexity.
Yeah, there's lots
We
of it.
want to understand what uterine inertia actually is, what causes it, how vets diagnose it, using the tools and tests in these sources, and importantly, what the sources suggest can be done.
Right.
We're basically distilling the key info for you.
And it's fascinating, isn't it, how critical this is during parturition, the birthing process.
Definitely.
Our sources define uterine inertia as, well, essentially a failure. The female can't expel fetus's normal size, normal presentation through a normal birth canal right at the expected end of gestation.
So not just a slowdown, but a real failure of the process.
Exactly. It's a pretty significant hurdle, and it can affect any any age.
Right, and the sources are clear.
Yeah,
It's not just one thing, is it? But they talk
Yeah.
about two main types.
that's right. Primary and secondary uterine inertia. And there are quite distinct challenges, need different approaches.
Okay, let's start with primary. What's the core issue there?
So primary uterine inertia, that's a failure to even initiate normal progressive contractions. Labor just doesn't start when it should.
Just doesn't get going?
Nope. And the sources say it's multifactorial. Lots of things can contribute.
Like what, for instance?
Well, one thing the sources highlight is seeing it in large breed dogs with really small litters, maybe just one or two puppies.
Why is that?
The thinking is there just isn't enough fetal stimulation, to kickstart labor properly.
Okay.
But here's where it gets kind of interesting, almost paradoxical. The sources also say it happens with very large litters.
Wait, large litters too?
By the
How does
way-
that work?
Overstretching, the uterus is just stretched too thin, too much, making effective contractions difficult, maybe impossible to even start.
Wow. Okay, so either extreme too few or too many can stop labor from starting at all. That's a key point from these sources.
It is.
Interesting. Now, what about secondary uterine inertia? That sounds like labor does begin, but then just stops.
Exactly right. Secondary inertia happens after parturition has already started. Contractions begin, maybe she delivers some of the litter,
Uh-huh.
but then they just stop. The dam stops contracting before all the puppies or kittens are out.
Okay.
And the sources mention this can happen after some are born, and it's often, well, secondary to things like the uterine muscle just getting exhausted.
Right, like it runs out of steam.
Yeah, especially with prolonged effort, maybe a really big litter causing fatigue, or during dyscosia, that's a difficult birth where the uterus just tires itself out.
Okay, so primary never starts, secondary starts, then stops. If you're watching a dam, how do you recognize these signs based on what the sources say?
For primary, the main sign you'd see is just nothing happening. Failure to start labor when it's due.
She might seem fine otherwise.
Often, yeah.
Yeah.
Maybe some vaginal discharge if a placenta separates inside, but outwardly she might look okay. But the critical thing, the sources stress this, is that unseen, the fetal heart rates start declining the longer you wait to intervene.
Ah, okay. That's crucial. And for secondary?
With secondary, you see those initial contractions, maybe some births, but then it just stops. No more progress.
And the heart rates?
Same issue. Fetal heart rates decline over time if intervention is delayed. That decline is a major, major red flag in both types, according to these papers.
That makes total sense. Time is absolutely critical here, isn't it? The sources really seem to hammer that home.
Definitely.
Now, let's dig into the causes. What are the specific reasons behind each type, according to these readings?
Well, the causes are pretty numerous, complex, really. For primary, like we touched on, not enough fetal stimulation from small litters is one thing.
Right.
But also maybe abnormal hormone levels or not enough hormones, or maybe the uterine receptors for those hormones aren't working right. Systemic diseases in the mother, obesity, certain drugs, tocolytics. The ones used to stop labor are low blood calcium, so hypocalcemia.
Calcium's important then.
Very. Uterine infection, even things like inadequate or unbalanced nutrition during the pregnancy, all possible contributors.
Wow, that's quite a list for primary failure. What about secondary causes?
Secondary is often about exhaustion, uterine muscle fatigue,
Just worn out.
pretty much. From prolonged, really strong effort, especially with big litters or during dystocia where it's struggling against a blockage. Less common causes, the sources mention uterine torsion twisting or trauma.
Okay, so if a vet suspects uterine inertia, how do they figure out what's going on, which type it is? The sources must outline a diagnostic path.
They do, yeah. It's a bit like detective work. First, rule out other
Like
things.
kind of things.
For primary, you need to be sure it's not just an inaccurate due date,
Right.
or maybe a false pregnancy or a non-viable one where labor wouldn't start anyway.
Makes sense.
For secondary, you need to make sure it's not just a normal pause between puppies that can happen or that she hasn't actually finished already.
Right. Rule out the simple stuff first. What about actual tests the sources discuss? Blood work.
Blood work's important. The sources note some things, like a certain type of anemia and high cholesterol, are actually normal in pregnancy. So those aren't necessarily alarm bells on their own.
Okay.
But crucially, they look for low calcium, either total calcium or specifically ionized calcium, the ICI. That's the active form.
So calcium levels are key.
Definitely. Low calcium, hypocalcemia is a big factor. They might see low blood sugar, hypoglycemia too, but the paper suggests that's not usually thought to be the main cause of the inertia itself.
What about hormones? Progesterone is vital for timing labor, isn't it?
Absolutely. Serum progesterone. That's a critical piece. The sources say for normal labor, progesterone usually drops below 2 nanograms per milliliter.
Okay, less than 2 in GML.
Yeah, and stays there for about 48 hours beforehand, usually. If it hasn't dropped significantly, true labor probably isn't imminent. That points more towards primary inertia.
Got it. Beyond bloods, I assume imaging is crucial. Seeing inside.
Oh, for sure. Ultrasound. Primarily to check if the fetuses are viable, alive and well.
And those heart rates again.
Exactly. The sources really emphasize this. Sustained fetal heart rates below about 160, 1170 beats per minute. That indicates stress.
160, 170.
Okay. And that means intervention is needed, like now. They particularly stress if you see placental separation on the ultrasound. That requires immediate action for any chance of survival.
Wow. Okay. That 160, 170 BPM feels like a really critical threshold. What about x-rays? What do they add?
Radiography, x-rays, they help evaluate the presence of fetuses, check their size, and look for any abnormalities in how they're positioned, their presentation, posture inside the birth canal.
So checking for blockages, essentially.
Exactly. It helps see if they're lined up okay or if something's physically blocking the way. That's really important for figuring out if secondary inertia might be due to an obstruction.
Makes sense. And a physical exam, too, I imagine.
Yes, a digital vaginal exam is crucial. Feeling inside to check if a fetus is right there in the birth canal near the exit, and also to assess the canal itself for any anatomical issues like narrowing. That kind of physical blockage can definitely cause secondary inertia because the uterus just can't push past it.
Okay, so we've got the types, the signs, the causes, and the diagnosis using all these tools.
Right.
Now, the big one, treatment. Once it's diagnosed, what do the sources say are the options?
Right. Treatment. It really hinges on the type of inertia and, most critically, the state of the fetuses.
Fetal status is key.
Absolutely. And the sources are very clear. If there are live fetuses and you've confirmed fetal stress, especially with those low heart rates on ultrasound,
Yes.
the best option for survival is an immediate C-section.
Okay, so surgery is often the go-to for distressed pups or kittens, or if labor just isn't starting.
Yes, particularly for primary uterine inertia if the goal is live fetuses. The sources basically state surgery is the only option offering a good prognosis for survival in those cases.
Right.
Supportive care too, of course, like IV fluids for the dam if needed.
What about medical management? Can you just give meds to kickstart contractions?
Medical management is discussed, but the sources really stress the limitations. It's only considered appropriate for secondary inertia.
Okay, only secondary.
And only if a full exam and imaging confirm there's no obstruction, no blockage, and very importantly, no signs of fetal distress on the ultrasound.
That seems like a very narrow window.
It is. It's definitely not the first choice for primary inertia or if those fetuses are stressed.
Okay, so big caveats there. For those very specific cases, not obstructive secondary, no fetal distress, what meds are mentioned.
Well, if they go that route and low calcium, hypocalcemia is concerned, they use 10% calcium gluconate.
How's that given?
Subcutaneously under the skin or slowly intravenously, IV. The sources give dose ranges for dogs and cats. But, and this is a crucial warning from the sources, IV calcium carries a risk of cardiac arrhythmia.
Oh, affecting the heart rhythm.
Yes. So continuous ECG monitoring is recommended during IV administration, and they say stop immediately if an arrhythmia occurs. Interestingly, though, sometimes just correcting the calcium and rehydrating might be enough to get contractions going again in some secondary cases.
What if the dam has low blood sugar?
If hypoglycemia is there, then dextrose-containing fluids are used to fix that.
And what about oxytocin? That's the classic labor drug, isn't it?
It is, but the sources state it's not typically effective as the sole treatment for true uterine inertia.
Not a magic bullet, then.
No. If it is used, it should generally be given about 15-30 minutes after the calcium treatment if calcium was needed.
Okay.
It's given either SC or IM intramuscularly. Again, dosages are provided. But here's another absolutely critical warning from the sources.
Let me guess. Risks.
Big ones. Oxytocin must not be given if there's an obstructive dystocia, a blockage.
Why not?
Huge risk of uterine rupture, tearing the uterus.
Wow. Okay, that's a serious warning. And the sources seem to imply that even trying medical management in those limited secondary cases carries a time risk.
Yes, they specifically note that delaying surgery while you pursue medical management might actually decrease the fetal survival rate overall.
So time is still of the essence.
Absolutely. It really reinforces that medical treatment is only for very specific, closely watched secondary situations, and surgery is often the default or certainly the preferred route for primary inertia or any hint of fetal compromise.
Right, so after the birth, whether it was medical help or a C-section, what's the follow-up? What monitoring do the sources recommend?
Post-treatment care is vital for the BAM. If she was hypocalcemic, her ionized calcium levels need monitoring.
Might need supplements.
Often, yes. Calcium supplements while she's lactating, especially if there is a risk of eclampsia. That's a really dangerous low-calcium condition after birth.
Okay.
The sources also say monitor her temperature and vaginal discharge daily for about 5-7 days post-dystocia or C-section.
Looking for infection.
Exactly. Watching for signs of metritis, a uterine infection, changes in color, smell, consistency of the discharge.
Gotcha. Were any tools mentioned for monitoring during labor, maybe to catch problems earlier?
Yes, actually. The sources mention tocodynamometry. They give an example of a system called Whelpwise.
What does that do?
It monitors the dam's contractions and helps track fetal well-being during parturition. It can be really helpful for spotting secondary inertia early.
Ah. So you can intervene sooner.
Right. Ideally before fetal distress gets severe. Allows for prompt augmentation if needed.
That sounds incredibly useful for breeders. Which brings us to prevention. Can anything be done to stop this happening in the first place, based on these sources?
They offer some strategies, yeah. Especially targeting causes of primary inertia. Well, if primary inertia seems linked to those small litters, optimizing breeding management, trying to increase litter size could help.
Okay.
They also strongly advise breeding females only when they're in good body condition, and carefully monitoring nutrition throughout pregnancy. Make sure it's adequate, balanced.
Good basic husbandry, really.
Exactly. And using that tocodynometry during labor, like we just said, can help spot secondary inertia early, allowing for quicker, maybe less risky intervention.
Makes sense.
And here's another really significant point from the sources. They recommend removing animals with repeated primary uterine inertia from breeding programs.
Removing them? Why?
Because it's thought to be heritable, passed down genetically in some breeds of dogs and cats.
Wow, heritable.
Yeah.
That's a major takeaway for breeders, isn't it? Planning future litters.
Huge implication.
So what are the potential complications if things are delayed? And what's the general prognosis for dams who've gone through this?
Well, the main complication, sadly, is fetal death. Losing viable puppies or kittens if too much time passes before intervention.
Right.
And as we just noted, that suspected heritability of primary inertia is a critical factor for prognosis, especially regarding future pregnancies.
And the expected course. If a dam has primary inertia once, is she likely to have it again?
For primary inertia, the sources say yes, it may recur in later pregnancies.
So what do you do then?
In those cases, an elective C-section can be planned ahead of time. That optimizes the chance of fetal survival, avoids the emergency.
Okay. What about secondary inertia? Does that tend to repeat?
Not necessarily. The sources suggest secondary inertia won't necessarily recur if the original cause was something specific to that litter or labor, like just exhaustion from a really huge litter, or maybe one fetus was malpresented, causing a blockage and prolonged effort. If it wasn't due to an inherent problem with the uterine muscle itself, it might not happen next time.
Okay, that distinction matters for future breeding plans. Primary might be a recurring, maybe genetic issue, while secondary could be more situational.
Precisely. That seems to be the gist of it from these papers.
Okay, so let's try and bring this all together then, based on this deep dive into your sources. Uterine inertia, it's this failure of contractions during birth. Two main types.
Yeah.
Primary, where labor just never starts. and secondary, where it starts okay but then fizzles out. The signs are lack of progress and, critically, those declining fetal heart rates if you don't act fast. Causes are varied genetics, litter size extremes, both small and large, nutrition, calcium levels, a whole host of things.
Yeah, quite a few factors.
Diagnosis involves ruling things out, then using tools like ultrasound for fetal viability, watching that heart rate x-rays for position and blockages, blood work for calcium, progesterone, and a physical exam.
That covers the diagnostic steps well.
Treatment really depends on the type and fetal status, often points to immediate C-section for primary inertia or any case with fetal distress.
Surgery is key there.
Or very careful medical management, calcium, maybe oxytocin, but with big warnings, only for specific non-obstructed secondary cases where fetuses are okay.
And even then, time is a factor.
Right. Follow-up means watching the dam for calcium problems, infection. And prevention involves good breeding practices, nutrition, maybe monitoring tools, and, critically, considering removing animals with recurrent primary inertia from breeding lines because it might be genetic.
That sums up the key findings from the sources very effectively. It's clear these papers show a condition needing prompt recognition and often pretty aggressive intervention for the best outcome for everyone involved.
Absolutely. And based on everything we've pulled from these sources today, especially the finding about primary inertia possibly being heritable and also influenced by nutrition, litter size, it makes you think, doesn't it? How does our understanding of this really challenge us to consider that complex interplay between genetics, the environment, careful breeding practices, all aimed at achieving successful, healthy births for our animals? It feels like it's much more proactive than just, crossing your fingers and hoping labor goes well.